Hi, my name is Professor Derek Willis. I'm Medical Director of Severn Hospice in Shropshire, so I'm overall manager medically wise for the Shrewsbury and the Telford end and the North Powys clip of the hospice, and clinically mainly work in Apley. But I'm here to talk about the project that I've been involved with, working in partnership with RJH Gaboin Hospital in Oswestry, where we've been treating people with adult neuromuscular diseases and looking at what palliative care could look like for those people.
What is the North Star Research Partnership?
Okay, so there's two things there. RJH, we've been running what we've called a symptom control clinic for several years now, which is for a group of patients who largely the neuromuscular service haven't seen that the hospice can be involved, and that's hospice nationally. And hospices, I don't think, have really understood what the particular symptom control needs of this particular group are. So we, as a hospice, started to work in partnership with the Neuromuscular Centre at RJH Hospital to kind of work out what this might look like. And the work that we've done with producing a symptom control clinic became known kind of nationally. The North Star is a particular project which is looking at adults specifically with Duchenne muscular dystrophy, which is one of those neuromuscular conditions that we've been looking at. And for the first time ever, they have wanted to put a section in there with national recommendations for what adult palliative care should look like and what neuromuscular centres throughout the NHS should be providing for palliative care. And that is based on the service and the knowledge that we have had here in Shropshire between Severn Hospice and RJH. So it's become nationally known, and some of the elements which we'll come on to talk about have become known as the Oswestry Model. So Shropshire, a place in Shropshire, is being named nationally. So great news for us as a region.
What motivated the collaboration?
So my wife is the consultant at RJH, and she's got a particular interest in children and adults with neuromuscular disease. And there was a patient who was in the catchment area for the hospice, and she wanted to refer the patient to us. And basically, because of some of the other healthcare professionals who are involved, the feeling was that the adult hospice was too gloomy. And so that patient died at home without the support that we as the hospice could provide. And we just thought that was awful, that here's this, hospice with a consultant who wants to learn, that we wanted to try and make sure that position didn't ever happen again, that families and patients understood what it is that we did as a hospice, but also the wider community knew that the hospice was a place that was welcoming to such people. But we're also aware that we didn't really know what palliative care should look like for such a group. And so we wanted to develop it and work on it and make sure that didn't happen in Shropshire, but more widely, that actually didn't happen within the UK. And now, towards the beginning of 2025, it now looks like we've got an opportunity to make sure that that's not going to happen in the world.
Duchenne is the most well-known muscular dystrophy. Have there been any recent changes regarding the condition?
That's a really good question, because that also answers why are we now thinking about this now? Because kind of years ago, within my living clinical memory, patients with Duchenne muscular dystrophy were dying late teens, early 20s. So most of their care was within children's hospices. Now, because of various kind of changes in medication and the way that this particular group of people are cared for, these folk are now living into their 30s. So actually, for a lot of children's hospices, they're too old, or they're not actually needing a children's hospice. So it's almost as if we're discovering a completely new disease, which is adult Duchenne muscular dystrophy. So what an adult hospice provides is different from a children's hospice, which a lot of the emphasis is on respite. Adult hospices don't provide that. But we know that there are lots of symptoms that patients with Duchenne muscular dystrophy have. So we're starting to understand the particular way that we can help lads who've got Duchenne muscular dystrophy and their families, and what they need from us as a hospice and what we can provide. And that was very much the starting point with Duchenne muscular dystrophy. But We started to discover that there were lots of other diseases which go under the umbrella of neuromuscular disorders, so things like myotonic dystrophy, that actually are quite similar to some of the diseases that we look after, so things like motor neuron disease. But neuromuscular centres have never thought that we as hospices can provide care or symptom control for them. So we started with Duchenne muscular dystrophy and have branched out to all these various other neuromuscular disorders. I guess the other thing is these diseases are really, really rare. So some hospices may only have one patient in their area that's got this. Because I'm working in partnership with RJH and its catchment areas, North Wales, parts of Cheshire into Liverpool, kind of bits of West Midlands, there's more of a concentration of those people. So as a palliative care physician, I could gain some understanding of it and help local services, so-called hub and spoke. So not only as an individual hospice are we gaining knowledge with this, I'm acting as a resource for other hospices and plugging patients from RGH into their own particular communities and services that are there.
What were the research objectives?
The overall aim is that we wanted to improve the quality of life of adult patients who had neuromuscular disorders. So we wanted to do that by encouraging people who are neuromuscular specialists to identify particular patients that they could refer into palliative care services. And we wanted to upskill palliative care services so that they understood some of the things that they might want to get involved with. But we also wanted to empower patients and families to say, actually, your perception of what hospice is like, of just being death and dying, is not the entire story. Yes, so sometimes this is a place where people come to die because the death is complex and needs symptom control and involvement. But an awful lot of our work is dealing with symptom control for people who are at a particular stage of their disease where active treatment is no longer appropriate. So we wanted to improve the care, but actually wanted to start to understand what that care looked like. And I think we're really starting to grasp that. But it's an ongoing journey, which the neuromuscular specialists, us as palliative care physicians, but patients and families are really starting to understand. We thought that we would be met with resistance from the kind of neuromuscular community, but actually quite a lot of patients have been saying, this is kind of what we've been waiting for. We've just been waiting for you to catch up and to tell us what it is that you could provide. So the aim changes, but I guess the overall thing is that we just want to improve quality of care and make sure it's not patchy. So what started to happen in Shropshire, we want to make sure that it's available throughout the UK.
What have been the key findings of the research?
What we found is that there are probably two distinct stages that we've identified. The first stage is, should we now be having conversations with patients about what their future wishes are? So you've reached this stage in your disease where perhaps disease-modifying drugs aren't available or the disability has gone so far. Do we need to be talking about whether you want to go to hospital or not, under what circumstances you want to go to hospital, and actually start to think about, as things accelerate and maybe patients are dying, what their death should look like? And then we've started to identify when it is when someone like me should become directly involved. So when there are symptom control issues. So when we started, we sort of had a one-size-fits-all review system, which we call the traffic light system, which was for any neuromuscular disease. What we started to research is to find that we've got specific traffic light systems now for specific diseases. So we have one specifically for Duchenne muscular dystrophy, which we are auditing nationally at the minute. And we've got one specific for myotonic dystrophy type 1. Our next stage is that we're putting forward to a European grant to go to Amsterdam and get everybody who knows anything about this throughout Europe and the world to create guidelines for patients with facioscapulohumeral dystrophy and looking again at myotonic dystrophy. So starting to get more of a European focus, and also with this group looking how we can roll that out so that that becomes a standard that other European countries in particular are doing.
What should palliative care for neuromuscular disease patients look like at different stages?
What we found, particularly with patients with Duchenne muscular dystrophy, if I'm going to say Duchenne muscular dystrophy, I'll use the phrase DMD because it's just less of a mouthful. So DMD from now on is Duchenne muscular dystrophy. Because a lot of these, they're young adults, And a lot of them, at the particular stage that we're talking about, will actually have wheelchairs. Finding a space for particular people for guys to meet and just socialise with each other, but also maybe get someone in to kind of go through a topic that they want to talk about is difficult. We've started to use our space at the hospice so that they can actually use the room, because the room's big enough to be able to fit the wheelchair. So in that sense, we're not particularly doing anything. We're just providing a space. And if the guys wanted us to go and talk, we go in. So there's that within an early stage. So it's sort of normalizing what a hospice is. We're providing training for the people that are involved directly with neuromuscular disorders, that they can start having these conversations about advanced care planning. It feels wrong for us as palliative care folk to kind of swoop in and start having these significant conversations when actually a lot of the team will have known these lads for a very, very long time. So having that conversation seems to be more natural from the existing team. And also it's a kind of drip feed conversation. It's not the we're having it now. It's something you start suggesting as you go along. And I think the biggest role that we have is providing advice and actually providing clinics. So I do 5 clinics a year. We used to kind of do one at Telford and one at Oswestry. We're finding it was difficult for people to get to, and they used to go to Oswestry. So I do it now at the hospital itself. And sometimes do that virtually, because post-COVID, we've discovered Teams, and for a lot of the patients with all the muscular dystrophies, getting out and getting transported around is difficult, whereas a lot of them are very tech savvy. So some of the clinics that we'll do will be online. So palliative care is to provide a space, provide training, and provide advice on symptom control.
Could you tell us more about the types of neuromuscular disease?
So when we're talking neuromuscular diseases, we're talking about the muscle itself, the junction between the nerve and the muscle, or the nerve that's coming out of the spine. So that the kind of what's called the peripheral nervous system. So the disease that most people will have heard about is Duchenne muscular dystrophy. Duchenne muscular dystrophy is a muscle disorder which affects skeletal muscles, so the muscles that help you move, the muscles in your heart, and also the muscles in your gut. And also because it's skeletal muscle, that's also the muscles involved in breathing. There's a particular way that Duchenne muscular dystrophy is inherited. And because of the inheritance, which is on the sex chromosomes, it's boys / young men that will have Duchenne muscular dystrophy. Because of the genes that are there. Some women who are called carriers, who will have one version of the gene, will and have a normal gene on the other side, so that doesn't get expressed as much, will be what be called symptomatic carriers. So some kind of young women will have features of Duchenne muscular dystrophy, but they're not classed as having full Duchenne muscular dystrophy. It's a carrier status. So that's Duchenne, and I'm guessing that's the one most folk will have heard of. There's another disease called myotonic dystrophy, which again is a muscle disease where patients are unable to relax their muscles. Once they've contracted them, they find it very difficult to relax them, and patients get very fatigued. So the classic thing that medical students will have in their exam is they will be asked to shake the hands of someone, and someone with myotonic dystrophy won't be able to let go because of the particular genetic disorder that the patient has. That's got a very different way of it being passed on, and that tends to be equally seen both in men and women. And every generation you will find will have myotonic dystrophy where that gene is actually expressed. So the two big ones really, and the ones that we've got the most evidence for at the moment, are for patients with Duchenne muscular dystrophy, so men, and tends to be younger men, and myotonic dystrophy where it's what's called autosomal dominant, and actually tends to be, again, within cluster of families, but every generation of that family.
What have been the key outcomes from this collaboration?
Our guidelines for how patients with Duchenne muscular dystrophy who are adults should be treated and reviewed, palliative care is in there. And that's the first time that's ever been. We now have guidelines for patients with myotonic dystrophy, which is just at the minute specifically for England. That's the first time that there's ever been anything on palliative care, and they're out there. So we've actually produced national guidelines based on the work that's happened within Shropshire. The second thing that's happening is that this is a subject that's starting to be talked about within the neuromuscular community as a whole. So I've been asked to arrange a conference which will be happening in Amsterdam, where we're going to be looking specifically at advanced care planning for some of the more rare neuromuscular disorders and deciding where the research across Europe is going to happen in the future. The other thing that's happened is that I've been asked to go to Vienna to the World Muscle Society in October, again to present our research and our findings. This is the first time ever that adult palliative care has been an invited speaker at a conference like this. So not only is it great for palliative care, it's hugely significant for Shropshire that there's work that we're doing here that is nationally and internationally being picked up and wanting to be replicated or moved forward. So it's great. But the most important thing is that we have had patients whose quality of life has improved. We've been able to do better symptom control. We've been able to make sure that patients are at home pain-free. But also we've had some patients who we've been able to die at home and have the support that other patients with other conditions would have had, but applied to a neuromuscular disorder. So all these things that are national and international are great, but if we're not making a difference to patients, it doesn't count as much. And I would argue it really does. And what I'm hoping is that other places are going to find that out as well.
What challenges did the team encounter while developing these guidelines, and how were they addressed?
I think our big problem was perceptions from both sides, in that when we've gone outside of Shropshire, neuromuscular specialists have said, well, you're too gloomy and actually you're all about death. And hospices sometimes, when they've been outside of the region, have saying, we don't look after those kind of people. It's a bit too scary, it's a bit too complicated, it's too new. Whereas when we're actually saying, look, there's a neuromuscular specialist and a palliative care doctor, and we think we're onto something. And actually, neuromuscular specialist, actually, we can help you with the symptom control bit. Death and dying does happen, but the main thrust of what we're trying to do is to work out what symptom control is. So that's work from that end, and just getting out there and having the conversation. And as more people have seen what we're doing, we keep being asked back. And then supporting hospices. So they'll often have one patient and go, look, I'm a resource. I can help you. I can't look after the patient because they're in your catchment area. But here are some of the things that you need to be thinking about. And the sense of satisfaction that hospices have had of getting it right for patients who first seemed like they were complicated. And then you realize that actually some of this is what we do, but some of this is complicated because we're not used to it. But actually, if we're about symptom control, which we are, it can't just be one specific disease that we look after. It needs to be all of them where the symptom control issues are a problem. But also this group of people are very rare, very complex. It actually needs an awful lot of intervention. So it needs specialist palliative care to help out with the palliative care that this particular group of people need.
What is the Oswestry model, and how has it been used in advanced care planning and symptom management?
So what we wanted to try and understand is when we needed to have conversations about future care and when someone like me needed to be involved. Because it's obvious that at some stages of the disease, actually talking about palliative care is really inappropriate because the person's not at that stage. So what we did was that we looked at what neuromuscular diseases as a whole tend to do and identified when as a whole they tend to be amber. And amber was when this is when we need to have advanced care planning. So that's if a person reaches the point where they're unable to tell us what their preferences are, we've got some record which gives us an idea or a flavour of what it is that they would want if they could tell us. So that helps both family and healthcare professionals. Red is actually where they've reached the stage of their disease where symptom control and being known to local palliative care services is really important. So it's a traffic light system because it's actually got kind of red, amber, green. And we wanted to call it the Oswestry model because actually we don't have enough in the sense of experience because these diseases are so rare for it just to be Shropshire. But the way that neuromuscular centres work is that they'll cover several regions. So what you can have is your neuromuscular centre as a kind of an area of expertise and have a palliative care consultant from one bit of the region that provides advice. So you can run a clinic from there. But then they can get in touch with the services and what's available within that person's own community. So the hub is the Neuromuscular Centre, where you have a palliative care specialist who gives face-to-face advice or kind of one-on-one. And then you actually work as a spoke, because you can help the hospices where these particular neuromuscular patients are going to be. We now have traffic light systems because we've started to be a bit more specific at the moment for Duchenne muscular dystrophy, DMD, of what the particular disease process is that. So what kind of green, amber, red looks like for that. And then for myotonic dystrophy type 1. So it's worked really well. We've audited and found that we are capturing people just at the right moment. What we're now going to do with research is to take 4 neuromuscular centres and apply the traffic light system to the 2 different specific diseases and go, right, how many of your current cohort, when we apply the traffic light system, should you be having a conversation about advanced care plan, and should palliative care services be involved? So it kind of gives us an idea outside of what we've got at Shropshire of what the actual need is and how that translates into how many patients each hospice might expect to have with this particular type of conditions.
What is the international interest in this work?
So palliative care very much started within the UK, and palliative care started to branch out into other countries. Through us, because I mean, it makes it sound like this has happened overnight, but it's been years of just plugging away at this. But through years of going to various conferences, presenting posters, so just being there and discussing about this, actually there's been a bit of a change to go, this is really, really important. Folk may have heard that there's various new exciting treatments for some neuromuscular disorders with gene therapy, and it's changed the landscape of some conditions. Having said that, there are some conditions still, myotonic dystrophy, where actually the prognosis hasn't changed. So the challenge of actually trying to get across to people that this can be parallel planning, you can be looking at ways that are cure, but actually we really do need to be thinking about how we do palliative care more effectively, especially because some of these conditions, people may have actually seen their relatives die of this condition. It's not like you've got a new diagnosis of something you're not familiar with. A lot of people will have already watched relatives die of a particular condition. So actually not having the conversation is really unhelpful. So what we're hoping is that at the least we can actually start getting advanced care planning as something that's discussed, and then try and look at palliative care and how that can be delivered, understanding that the hospice movement is not as well developed within other countries. So I'm ambitious and want things to change, but even I haven't got enough time to make sure that the hospice movement is the same in every country. But I think at least having advanced care plan discussions and empowering people to think about what symptom control looks like, I think that's something we can achieve. And actually there are signs that we're starting to do it.
What are your next steps and new areas or aspects of care?
Okay, so what we're trying to do is to gather more national data. We've reached the point where we can go past what we're doing at Shropshire, and we need to get more data because it becomes more powerful and more meaningful. But we've actually got some real enthusiasm from some other places who want to run the same thing at the same time. So then we kind of run it for a year or so and gather that data together and have more idea of what's involved. Because we've had such small numbers in Shropshire, because they're rare diseases, we haven't built up an idea of what the specific symptom control issues are. We know that symptom control issues were for this patient or that patient, but we don't really know what the trends are for specific diseases. Once we get more of the groups together, we can actually understand that more because we've got more data from more patients and more understanding. So the ambition is, and where we're going to go next, is try to understand the specific needs that each neuromuscular disease has and what the best drug regime or the best interventions are to try and help with those symptoms.
How do you see palliative care for adults with neuromuscular diseases evolving in the next 5 to 10 years?
What I really, really hope is that to have a YouTube video or whichever media you're looking in 10 years' time won't be special. Because the reason is it will just be standard practice. That each patient won't be lucky with what they get because of where they live, that actually wherever a patient lives, they'll get a standard evidence-based palliative care input from a neuromuscular centre that works really closely with palliative care colleagues. So I almost want to do myself out of a research job, because actually everybody will have accepted this and it just becomes standard practice. Hopefully that's 10 years, maybe longer, but we'll keep plugging away at it, and that's what we want to achieve.